The October 31st, 2013 issue of the New England Journal of Medicine had a great article on circulatory shock by Vincent and DeBacker. So I thought this would be a great time to go over this topic. And they defined the definition of this, the diagnosis of this, based on three components. There's an element of hypotension, hypoperfusion, and a high lactate, which means that there's abnormal cellular oxygen metabolism. So let's look at these three in a bit more detail. The blood pressure, it's best to measure an arterial blood pressure, maybe through an A line, and you might get a systolic blood pressure of less than 90, or a mean arterial blood pressure of less than 70. And there'll be an associated tachycardia with this usually. Now, one caveat here is that this blood pressure is for normal people. So hypertensives, people who normally run high, these numbers may be a little bit higher. The way that you measure the hypoperfusion, or at least the way that you observe it, is through what they're calling the three windows of the body. So you could look at the brain, and if the brain's not getting enough blood, you're going to have altered mental status. You can look at the kidney, and if the kidney is not getting enough blood, you can have decreased urine output. And finally, you could look at the skin, and if the skin isn't getting enough blood, then you're going to get cyanosis. So I'm depicting that as this hand with purple skin to represent the cyanosis. And if you'll remember from the Krebs cycle, when you get into anaerobic metabolism, you start forming lactate. And so when you're not getting enough oxygen, you're going to be forming lactate. And the normal level of lactate in the blood is 1 millimole per liter. So an increased one would be 1.5 millimoles per liter. And frequently in septic patients, you can see numbers of 4, 5, 6, 8, 10, 15. I've seen some very high ones. So let's depict this pictorially, as you know I like to do. And here we have a schematic. This is the heart. This is the arterial system, and this is the venous system going back into the vena cava, and these are the lungs. And then here again are our windows, the brain, which reflects decreased perfusion by altered mental status, the kidney by decreased urine output, and the skin by cyanosis. And so now we have four different kinds of shock. And the first one is hypovolemic shock. That means that there isn't enough fluid in this system, and so that's why there's not enough fluid to pump to these organs. So this could be from blood loss, it could be from dehydration, it could be from all sorts of reasons. The next cause is cardiogenic shock, and that means that this heart isn't doing well, so it cannot pump the fluid to our organs. And so maybe you have a heart attack or myocarditis or some sort of dysrhythmia that's making inefficient pumping, so you need to fix that. The next kind is distributive shock, and you can see I've expanded the blood vessel here, and what that means is blood is being distributed to other areas that it shouldn't be going to, and mainly that could be the blood vessels, or maybe the blood vessels are even leaking some. So you can see this in states like sepsis or anaphylaxis, where there's inflammatory mediators that are causing dilation of blood vessels. And the final kind that you can get then is obstructive shock, and that means something's blocking the blood flow from going through. So there might be enough fluid in the system, and the heart may be pumping perfectly well, but it can't get past this. And so this can happen if there's a block in the blood vessel itself, like a pulmonary embolus, or there could be something that's blocking blood from getting into the heart, such as a tension pneumothorax or a cardiac tamponade. There are two other ways that I've seen this categorized. So people will say that there is a problem with either the pump, the tank, or the pipes. I guess this is a plumbing analogy, and the pump obviously means a heart problem, and so that would be cardiogenic. The tank refers to the amount of fluid in the tank, and so that's hypovolemic shock. And something wrong with the pipes would mean that you have something like a distributive shock, where the blood vessels are all opening up, they're vasodilating, and so you have problems with the pipes, like as in distributive shock. I guess you could also say that a clot within the pipes is a pipe problem, and that's an obstructive shock. issue. The other categorization I've seen is categorizing them as either low cardiac output or high cardiac output. And if you think about the pictures that I drew, you can probably figure out which goes in which. So if you don't have enough fluid, you know that there's not going to be a lot of cardiac output, right? So hypovolemia would go in here. If the pump is not working, if the heart's not working, you're also going to have low cardiac output. And finally, if something is blocking blood flow, like an obstructive shock, you're going to have low cardiac output. Now you'll have high cardiac output if all of that is working. It's just you're pumping fluid into too big a space because everything is vasodilated, right? So that's distributive shock. So they had a wonderful picture in here, which was a pie graph showing how common is each type. And by far the one that wins is a septic shock. And that's, of course, a kind of distributive shock. Other kinds of distributive shock, so that'd be like anaphylaxis, only account for about 4%. Then in a tie, for the next most common, would be cardiogenic and hypovolemic. And then, of course, the last little sliver there belongs to obstructive shock. Not the most accurate pie graph, but you get the idea. This 4% looks smaller than that 2%. But the idea is that septic is the biggest piece. Cardiogenic and hypovolemic are next. Now, the problem is that sometimes when you got someone who is showing signs of hypoperfusion, maybe they got mottled skin, they're altered, their blood pressure is very low, or you check a lactate, as I depicted here by the syringe, getting a blood test and look, the lactate is 8, then know you got some kind of shock going on. But it might not be easy to tell which one you have. Is it cardiogenic, obstructive, hypovolemic, or distributive? Probably it's septic, but it might not be. And a really good way to do it is to do echocardiography. And so I'll enlist one of my ultrasound friends to help us with a video on that. But what you can do with echo is you could look at each one of these things. So if you're looking for hypovolemia, you could look in the IVC. Now this is my very poor ultrasound depiction of the heart in the IVC, but for hypovolemia, you look at the inferior vena cava, and when there's not enough fluid in here with breathing, the thing collapses on itself because it's just not enough fluid. When you have cardiogenic shock, you're going to see the whole heart itself is just not going to be pumping well. With obstructive shock, maybe if you have tamponade, you'll see fluid collecting in this space here. Or if you have PE, then what's happening is blood is not getting out of this right side of the heart. And so you'll see this right side of the heart is dilating, and so you'll be able to see signs of the obstruction, or at least the effects of the obstruction. And finally, with distributive shock, remember the heart is pumping. You'll see none of these things, and the heart is pumping very well, and it'll probably be hyperdynamic because this is a high cardiac output state. So this was just a quick introduction to the various different kinds of circulatory shock. Remembering that we had three ways that we were, three clinical features. We were looking at the blood pressure, signs of decreased perfusion and increased lactate. We categorized it according to 4 types: cardiogenic, obstructive, hypovolemic, and distributive. Or we could do it as low cardiac output and high cardiac output. We know that septic is most common, and it's very difficult, though, to tell. One thing that can help us is an ultrasound of the heart. In the next video, we're going to look at the approach to the patient in shock. Okay, see you then.